Welcome everyone to today's webinar. I'm Alan Conlon with Becker's ASC Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We look forward to hearing your questions. This session is being recorded and will be available after the event. You can use the same link used to log into today's webinar to access the recording. At this time, it's my pleasure to start today's webinar by introducing our presenter. Adam McMillan has spent his entire career developing spine and orthopedic medical devices and biomaterials. He has a passion for innovative design, additive manufacturing, and nanotechnology. He currently oversees new product development as Vice President of Marketing at CoreLink by day and is a ceramic artist by night. At this time, I'm pleased to turn the floor over to Adam to begin today's presentation.
All right, thank you, Alan. And before I introduce our guest speaker today, Dr. Marc Weinstein, I'd like to take a brief moment to just introduce CoreLink and the subject device of today's discussion, the FlexFit 15. This device is an articulating, expandable interbody T-lift device capable of up to 15 degrees of lordotic correction and 4 millimeters of height with continuous expansion. One of the many benefits of this device, as Dr. Weinstein will discuss, is the ability to place this interbody device that has a contact area closer to an A-lift, but through a T-lift approach. And this is enabled by a hinge contained within the implant that allows for articulation once the device is into the disc space. This is actually a technology that has been in the marketplace for about 5 years and was first commercialized by a company called Expanding Orthopedics. That first version of the device had a smaller expansion and lordosis range, but CoreLink acquired Expanding Orthopedics in 2018 and introduced a second version of this device with greater lordosis and expansion correction capabilities, and that's really what we're focusing on today. So for those on the call who don't know of CoreLink, we are based in St. Louis, Missouri, where we do the design, development, and manufacturing of virtually all of our implants and instruments in-house. We're a full-service, vertically integrated spine company, and we have a wonderful new state-of-the-art 70,000 square foot plus facility here, where we also have a nice private multi-station training facility, which is great for this current COVID environment. So for any surgeons on the call that would like to get their hands on the FlexFit device or really any other CoreLink system in the future, please reach out to me directly after the webinar. With all that being said, I'd like to introduce our guest speaker today, Dr. Marc Weinstein. Dr. Weinstein is a board-certified orthopedic surgeon in the practice of spine surgery, which he has been practicing for 21 years. He received his medical degree and performed his residency at the Yale University School of Medicine. He additionally performed a spine fellowship at the Hospital for Special Surgery in New York City and a clinical spine fellowship at the University of Miami Jackson Memorial Medical Center under the direction of Frank Eisman. He holds a position as an assistant professor of sports medicine and orthopedics at the University of South Florida, and he's a spine surgeon at the Florida Orthopedic Institute. He's published numerous research papers in both peer-reviewed medical journals and textbooks, and has lectured at national and international spine meetings. So we are honored to have him speaking on his clinical results of FlexFit 15 today. Dr. Weinstein, again, thank you for your time, and please take it away.
Great. Thanks, Adam. Thanks, everybody, for logging in and allowing us to share our experience with the device. Today, we'll talk about some of the rationale behind the use of expandable cages, particularly from the T-lift approach, and then we'll go over our data that we have after collecting patients for quite some time, but in our studies for at least a 1-year follow-up. So why are we using cages at all in the spine? These are used to enhance segmental stability, promote solid arthrodesis, to maintain the decompression of the neuroforamina, increasing disc height, and to achieve or improve segmental lordosis and sagittal balance. And I think that's one of the things we're going to focus on today, as it's been well documented, many papers published on the importance of sagittal balance with long-term outcome and quality of life in spine fusion patients. We're all probably by now familiar with some of the radiologic parameters that are associated with spinal balance and patient outcomes. In fact, patients that are outside of the optimal for spinal balance have strongly correlated with poor long-term outcomes and pain-related disability. However, this doesn't just, it's not only important for patients, surgeons doing deformity surgery. Degenerative surgeons are also responsible for noticing and improving sagittal balance. And in fact, when doing just single-level degenerative disease and fusions, we oftentimes can create issues. And we know that single-level fusions place adjacent segment stress. Long known is the biomechanical effects on the adjacent level. Particularly this study looks at compensatory hyperlordosis in patients that are fused in hypolordosis, such that every little bit of loss of lordosis increases the strain at the adjacent segment. And we've seen this clinically. Patients fused relatively flat then wind up having a compensatory hyperlordosis and adjacent segment breakdown. You can see this in a patient that was treated in our clinic who had a prior kyphosing or actually lordotic procedure with a TLIF. Started with L4-5 angle of 17, wound up with 5 degrees less lordosis, and then over even 1 year period of time wound up having compensatory hyperlordosis at the adjacent segment and breakdown and ultimately stenosis. We know from studies also that much of the lordosis of the lumbar spine occurs at the L4 through S1 segments, and that pelvic incidence is most often related to the upper lumbar spine in terms of where the correction can be made by each patient. Approximately 1/3 of the lordosis is through the L4 through S1 level. I'm sorry, 2/3 of the lordosis through L4 S1 level, making this level and surgery done on these levels a very important concept for even degenerative surgeons. Here we can see that even in single-level disease, when patients are out of balance, they wind up having adjacent-level surgery much more frequently. Again, in this paper, mismatch even after short segment fusions result in a worse outcome and is correlated highly with patient outcome. This is one of my patients early in the career where they had disease at 2 levels with stenosis, and you can see that this TLIF procedure left them relatively flat across the fused segment. After 2 years, they were able to maintain correction at the adjacent levels by compensating with a little extra lordosis. As you can see, this only lasts for some time. 6 years later, they're starting to get adjacent segment disease, and then 10 years later, quite significant adjacent segment disease. Whether or not this is related to the fusion flat from L4 to S1 is unknown, but certainly quite possibly a contributor to this. Dr. Uribe has performed this study where he looked at patients and their alignment pre-op and post-op for degenerative fusions. And as you can see, patients that were aligned before surgery, approximately 10% of them wound up worse off. And overall, patients wound up about 27% worse alignment post-op after degenerative spinal fusion. So again, even though the surgeons here are not addressing deformity, they are addressing degenerative disease that the patients are ultimately going to have to live with for some time in terms of their long-term outcome. So it's important to think about. So why are these patients winding up in kyphosis or less lordosis after a fusion? Well, some surgeons and researchers have felt that these cages, these static TLIF cages, could be kyphogenic in of themselves. This study looked at minimally invasive transforaminal lumbar interbody fusions and found that patients usually wound up with less than satisfying segmental lordosis through these levels, somewhere between 0 and 3 degrees, again, which is not particularly satisfying for patients, with lumbar lordosis changing anywhere between worse off at 6.8 to 14 degrees. So that might lead you to say, well, maybe it's not the cage, or maybe it's the TLIF procedures themselves that are kyphogenic. However, when carefully done by skilled surgeons, TLIFs in and of themselves should not be a kyphogenic procedure. And while Dr. Shafley does most of his surgeries in deformity, certainly he's shown that you can get pretty outstanding lordosis with 1, 2, or 3 level T-lifts when done with some thought and some skill. And his recommendations to achieve this are that even when doing single-level degenerative cases, you should always think about alignment. Open bilateral facetectomies are extremely helpful in improving or at least maintaining segmental alignment. Anterior cage placement, something we've all known about, and then even the cage type can be helpful. So some of the benefits or potential benefits of expandable cage technology is that they can improve disc height and foraminal volume. And some of the things that we found are most important is that they preserve end plate integrity and they can decrease neurological injury during insertion. We're always concerned with enhancing and maintaining the segmental alignment. And it's also possible that these will reduce expulsion and also decrease operative time. So when looking at the expandable cages, which there are now many on the market, I think these would be what I would consider in the ideal for the expandable cage. You want a large range of expansion so that you could put a very small device and expand it to wherever you need it in a disc space. You want to have the ability to accommodate graft material, although packing around the cage may be even more important. Lordotic expansion, we feel, is very important. These cages will reduce impaction forces, and a good cage will help you improve your MIS technique, which is sometimes patients are not getting bilateral facetectomies, and this could help improve the lordosis of the segment. It's nice to have a cage that can be collapsed if it needs to be repositioned or removed. And again, you want to be able to accommodate a variety of interdiscal anatomy. The 5-1 fish mouth is often problematic, particularly for static cages, but expandable cages fit really nicely in this setting. This biomechanics study looked at the force for impaction, how many times you had to hit the inserter. Obviously, with the expandable cage, it took less strikes for impact, so less damage to the end plates. These early studies looked at how to achieve best correction at the segmental level. Obviously, Smith P osteotomies are one way, but as you progress through static cages, large static cages, and then expandable cages, you're able to achieve more lordosis. In terms of the size or the shape of the cage is very important, such that wedge-shaped cages can produce more sagittal alignment lordosis than rectangular cages. Here you can see an example of the very small amount of real estate you have when putting these cages in. Larger cages oftentimes require larger traction on the neural elements. This is just a schematic to show some of the difference between sizes, that lordotic cages allow further compression across the pedicle screws, where an obliquely oriented straight cage, whether expandable or static, somewhat prevents you from compressing and achieving more segmental lordosis. Some of the first expandable cages could be considered wedge-shaped plinth cages, where you can spin a wedge-shaped cage in the intervertebral space, creating lordosis. We used these early on, and they created nice segmental lordotic changes. Again, other earlier type devices, some of which are still used today, are the mesh-filled bags of allograft bone, in which the device was placed in very small disc spaces and then were expanded using the bone. In this cadaveric study, however, you can see the mean increase in disc height was about 1 millimeter with not much increase in lordosis. And this is not too surprising, at least intellectually, when you think about expanding the device in the center of the vertebral body, which happens to be the weakest bone. You can see this is also oftentimes with a small oblique cage, a similar type effect, when you really want to put your supporting cages along the ring apophysis, where all the strong bone is, help you achieve anatomic correction. So since that time, cages have been engineered, all different types, sizes, We look at different things like the footprint, what kind of expansion you can get, how much height you can get with each cage. The length of the cage is important. Is it a continuous or incremental expansion? What kind of graft volume is important for some? And can it be removed once it's implanted? All these things are important when choosing an expandable cage. So when you sign into this and sign on to expandable cage technology, it's important to have a thought process involved. So are these cages really going to help us improve or restore or maintain sagittal lordosis or even global lordosis? Will these help MIS surgeons? I think the small portal of entry is critical and very helpful when doing these MIS. The question is the MIS technique one in which we're going to achieve great amount of correction? And then what kind of cage configuration, what kind of cage type is best is something we think about. And so we can look at some of this that's already been published in the literature, some MIS cages here. And while these cages were quite nice in improving disc height from preoperative 8.3 to 11 with great statistical significance, you can see here that even in this paper, focal cob angle, which wasn't really discussed, but you can look at their results, and that really was not really changed much at all. And you can see that here probably even was reduced somewhat with these cages. Here's another study looking at an articulating device in the spine. You can see that there's only been about 4 to 5 degrees of lordosis for this particular device. Another study looked at expandable versus static cages, and if you look at the segmental lordosis between the two, the static cage didn't provide any significant improvement, but the expandable cage did improve significantly the segmental lordosis statistically, and compared to static was a better device for that. Again, you can see the expandable in white, so all improvements in segmental angle. This study looked at multiple different types of cages for expandable interbody fusion. They followed patients for 2 years and found, although statistically significant, a very small amount of increase in segmental lordosis of 1.8 degrees, which wasn't particularly satisfying. This particular study looked at banana-shaped versus straight expandable cages and found that while the banana-shaped cage improved disc height significantly between the banana-shaped and the oblique cage, it wasn't able to significantly change lordosis, although they did get somewhat a trend toward improved lordosis with the banana cage versus the straight cage. Again, another study looking at expandable versus static cages for T-lifts. You can see that for the non-expandable versus expandable, they didn't really get much of a significant difference. However, when you look at this data, they were getting 3 degrees and 2 degrees of change in lordosis at the segment, really, which wasn't much at all, which makes you wonder about the surgical technique. So again, if we look at all cages across the board, and we start here in the upper left corner, you can see what I've designed as a static cage. So in order to fit that static cage in this space, you tend to put a large cage in, and then when you compress posteriorly, you have the potential of damaging the end plates and resulting in subsidence. Here you could take a lordotically angled cage and kind of ram it in and then damage the end plates along the way. Here you could place a non-lordotic expandable cage, and again, somewhat difficult to compress when the posterior aspect of that oblique cage is against the posterior aspect of the end plates. Or you can expand a lordotic cage inside the disc space, allowing you to achieve a little bit better segmental lordotic correction. Again, here's an example of static cages placed in the L4 to S1 segment, and you can see went from 43 to 33 degrees, so a loss of lordosis, which is exactly what we don't want to achieve for our degenerative patients. Again, here's an obliquely oriented or designed cage that was placed, it's designed to be placed straight, often placed oblique, but you can see this is expanded with very little fusion, and it's expanding through the end plates. Not much posterior compression can be applied when the cage is so far against the posterior end plate. Again, here's a patient who had a fairly flat spine through their prior fusion, even though they were done with ALIF. Has compensatory hyperlordosis here, but there was stenosis, and they were then given a TLIF device, which then actually took away their lordosis, even though it was an expandable cage, and now they're set for breakdown at the next level. So we started looking at the FlexFit device in terms of the above context to try to improve on some of the places where we've had experience and have noticed failure. So this device can be placed MIS or through open, which it tends to be still our favorite method. It's a titanium expandable cage that can now expand up to 15 degrees with continuous expansion along the way, and also with continuous 4 millimeters of expansion within the interbody space. It articulates, so it becomes a banana-type cage that we can place along the ring apophysis, or at least quite close to it. It has a very large footprint, and you can see it really expands across the disc space quite nicely. And, of course, it has a bulleted tip to help gain entry. There are two cage sizes, a 32 millimeter, or the one that we generally use in almost all patients, which is a 40 millimeter. Not many 40 millimeter TLIF cages on the market. You can see once it articulates, it winds up only being 30 across. So you really get to have a nice footprint in the interbody space here, with room both in this area, in front, and in within the cage for bone graft. You can see what it looks like collapsed and expanded. Again, this is kind of a busy slide, but you can turn the expander, and again, it expands in an incremental way. The 32 millimeter cage expands 3 millimeters in height in the interbody space, and the 40 millimeter cage 4 millimeters in height, both going to 15 degrees of lordosis. So again, we tend to do these through a small but still open procedure. We tend to use this for patients with severe stenosis. We're going to do them oftentimes open or do a mini open, and we're able to do bilateral fasciectomies, which are helpful. We do quite a significant cleaning out of the disc and exposure of the end plates. We use angled devices to get all the way across. We prepare the end plates all the time with a rasp. It also helps promote fusion. But the key is to remove as much of the complete discectomy as possible. And then you can see here, prior to placement of the cage, through a funnel, we deliver a bone graft, usually local bone, allograft bone, and some bone chips. So again, the technique is quite simple for TLIF surgeons. Again, you can do a trial first if you'd like. Again, packing as much bone graft in the body prior. You can see we also then pack the cage, and the device is placed. We'll show you later that there's something that prevents this from articulating until you get it where you want it. You allow it to then articulate, place it in your body space, and once it's in place, you can then expand it in a lordotic fashion. Again, there's a lot of room to pack bone if that's important to you. And again, here we are implanting the device through the TLIF approach. Try to get it over to the other side. You can see on the x-ray about where we place it. And then we will allow the cage to articulate by turning the sleeve, and then further unpack it through the articulation. Problems. So now, once the cages are articulated in the interbody space, where you can see, this is the device that goes in to expand the cage, and you can watch this expand in the interbody space. You can see that it's already allowing some segmental lordosis through this level. And we typically will expand this all the way. So we'll get 15 degrees of lordosis, 4 millimeters of anterior height. And so this is what the cage will look like once it's in place. Again, you can see within a 40 millimeter cage, it This is probably a 32, but 40 millimeter cage will get you almost all the way across. Sometimes it looks like a lateral interbody device. And here we go now, placing bone graft. You can see the funnel is in that V between the two articulating arms, such like this, so we're able to pack bone dorsally. We find this to be way more important in terms of fusion than any fusion that will grow through the small hole in any cage. You can watch as the cage goes in up top. You can see it going in and articulating around along the ring apophysis. And then on the bottom video, you can see the cage expanding in situ in the interbody space. Again, here the cage is already in position, and you can watch as we're now expanding the cage, and you can see the actual movement of the vertebral bodies into a much more segmentally appropriate position. Again, same thing here for this multi-level patient. You can see each one gets a little bit more as it expands down at L4-5, and here you'll see at L3-4. So some of the examples of how we use this, again, single level fusion here with severe stenosis at L4-5. You can see has excellent correction of lordosis. Again, fairly flat here through L4-5. Patients nicely lordotic at that level. Again, a 5-1 spondy, which is somewhat a difficult case when doing with just a TLIF. We're able to get nicely done there. Here's a patient of adjacent segment disease. Again, you can see the static cage relatively flat through that segment, flat through this segment. Now they have adjacent segment disease above. We can get some nice actual correction of lordosis at that level using that technique. Here's one patient that had a prior XLIF approach, which had reasonable results, then broke down at that level, and now excellent results with a TLIF and an expandable lordotic interbody cage. Unfortunately, that patient as well also broke down at the level above a few years later, but this allowed us to investigate this further, and you can see this patient has excellent fusion again around the cage. Allowed us to get a CT scan. Again, you can see a great improvement from 6 degrees to 16 degrees of lordosis in that region. And you can look here in the interbody space where there's fusion anterior to the cage, through the cage, and posterior to the cage as well. Just a little close-up view of the bone in the cage, also outside of the cage. And some other examples of a patient, again, 4-5 disease, who got some improvement in lordosis and height restoration. Here's another one here again. These big cages placed anteriorly with the force for expansion tends to lead to less impaction and then ultimate subsidence. Again, you can see sitting on the end plates nicely there. So we used this for some time and felt that it would be a good time to take a look at patients. We did a 2-part study. The first study was more of a historical. After we did our first 12 patients, we went back and we looked at single-level patients who underwent this type of approach with this device. And we compared them to a historical matched control static group. And we just looked at radiographic data to see how we were doing with segmental and pelvic parameter on x-rays after surgery. And then part 2 was we looked at a prospective group with single and 2-level FlexFit device, and we followed them clinically and radiographically. This study is somewhat ongoing for 2-year and 5-year follow-up, but we had completed 1-year follow-up, which we'll share with you today. So for that part 1 study, which was historical, looking at radiographic parameters only, we had our first 12 patients, which were 7 male, 5 female, around age 54. And they underwent this open single-level TLIFs. At that time, we were using a 10-degree cage. This was early on in our experience. And we looked at pelvic parameters and outcomes, and then we compared them with an age-matched, sex-matched, diagnosis-matched group of patients who underwent the same exact procedure by the same surgeon, except a banana-shaped PEEK cage was used. The results that we found was that we had greater improvement in segmental lordosis with the expandable cage at the L4-5 interspace with 6.3 degrees, L5-S1, which was 7.4 degrees. Expandable group had much less change in lordosis. We didn't see any subsidence in this group. And we define subsidence usually at change after 2 weeks. Change that occurs during surgery isn't really a subsidence. So what you see on your 2-week post-op x-ray is usually more of an impaction as a result of the surgery. So we can graphically look at this, and again, comparing the expandable to the static in terms of segmental lordosis in this group, you could see a significant improvement in the expandable cage and not really any significant improvement in the lordotic cage. In the static lordotic cage, while the expandables had significant improvement. Most importantly, what we found, and it's not unexpected, but it should be emphasized, is that we were using somewhere between 9 and 10 millimeter cages for our T-lifts, which admittedly sometimes were undersized because of the aspects of T-lift that we discussed earlier with the small amount of real estate, some of the difficulties in lordotic spaces. We didn't want to create end plate damage, but the expandable cage allowed us to effectively use a much larger cage, mimicking the more anatomic disc height, somewhere around 13 millimeters. This cage at the time only expanded 3 degrees, so we could have had even more. So again, I think this is one of the benefits of expandable cages, is that you can use effectively a much larger cage with less end plate damage and less neurologic compromise. So in part 2 of our study, which we're still collecting patients for, this is 36 patients, equally distributed male, female. Now they're age 62, so slightly older. And now they're undergoing 1-level or 2-level T-lifts. Again, these patients tend to have quite significant stenosis, so we like to do them open. We also feel that the bilateral fasciectomy is important for correction. We placed 49 cages, so that means 13 of the patients had 2-level surgery. We measured pelvic parameters, segmental lordosis, and we measured clinical outcomes with ODI and BAS, as well as SF-36 as well. Our results were that we had excellent results with pain and disability. I'm sure most surgeons get that when they're doing these procedures. They're quite good when done for the right indication. But we also, again, saw improvement in segmental lordosis of around 9 degrees at L4-5, 6.8 degrees at L5-S1, and when doing 2 levels, we were able to get about 10 degrees, not inconsistent from our initial study. We did not really notice much in terms, however, of overall improvement in lordosis, and we can discuss why that might be later. We didn't see any significant subsidence at 1 month or 6 months, really at any time point in this follow-up. Some of the graphic data. So patients, quite a significant amount of back pain and leg pain, pre-op, which was reduced markedly by 1-year follow-up. ODI, which pain-related disability, was dramatically reduced by 1-year follow-up. Again, results that are probably not inconsistent with most surgeries of this nature in patients with this diagnosis. But here you can see, again, the correction for single level L4-5, L5-S1 with all significant improvement from pre-op, no difference between 1 year and 3 months. Significantly, though, changed from pre-op for both L4-5 and L5-S1. when we looked at the total lordosis for 2 cages from L4 through S1, again, significantly improved from pre-op, but no significant change between 1 year and 3 years, but all significant from pre-op. So we're at least improving segmental lordosis at the levels as opposed to some of the results we've seen with static, where you barely get any improvement at all, and in some cases wind up losing lordosis. But when you look at overall pelvic parameters, obviously there's no significant change in pelvic incidence, but we don't really see much of a change in lumbar lordosis, perhaps a slight improvement in that, and not much change in overall pelvic tilt. This isn't unexpected for a 1 or 2 level fusion. This is just one of the patients in the study. You can see with he had spinal stenosis, a spondylolisthesis, fairly well balanced overall, with a Cobb angle at this level at 19. So in this patient, the last thing you want to do is make them worse or even fuse them with about the same lordosis in terms of long-term, where all our other levels are fine. So you can see this patient's stenotic disease, facet arthritis. So the patient gained about 7 degrees of lordosis, 8 degrees of lordosis, and had a fairly good outcome with fusion both posterior laterally in the interbody space, and was doing well. Again, so you can see pre-op and post-op. So in conclusion, we think that this expandable titanium cage allows greater improvement in segmental lordosis than using a static cage, especially when compared to a bananic lordotic cage, probably even greater so than oblique cages, although we haven't compared them to oblique cages. We feel that this device, or any expandable device for that matter, allows a greater effective cage size. So, I can tell you in my experience, perhaps when we first started doing TreeLess, we tried to put in 13 millimeter cages, and this just led to significant radiculitis post-op, subsidence. So a lot of times when using static cages, you wind up undersizing the cage, and using expandable cages allows you to get a nice anatomic fit, improve segmental lordosis, improve disc face height, as well as end plate contact. We don't really see that much for single-level fusions and change in overall lordosis. I think that's been borne out in other studies that looked at this as well. I think part of the issue is a lot of the patients don't have abnormal lumbar lordosis with single-level disease. I think the other reason is patients tend to find their own balance, especially in the older population. They tend to want to be forward, so you might correct them segmentally at one level, and they may tend to drift back to where they want to be. So I think overall lumbar lordosis is a lot more important when doing long fusions. But I think for degenerative fusions at single and 2 levels, maintaining segmental lordosis is important to protect the adjacent segments. We'll have to continue to follow patients in the long term to see clinically if this is important in terms of adjacent segment revisions to justify the use of these expandable devices. But at least in our 1 year and 2 year follow-ups, we're really not seeing any radiculitis, neurologic problems, and I think that's important, again, for placing a small device in the body space and expanding it, especially when from the posterior approach. So I think these cages will definitely have practical advantages, particularly this cage, through some of the rationale that we shared earlier. The peer-reviewed literature still is lagging here, although some studies are now starting to appear. We're going to have to continue doing research. But at the end of the day, using cages, screws, and all these devices for mechanical advantage does not supplant the use of meticulous surgical technique, which in the end is really what our patients are craving. Thank you very much.
All right, thank you, Dr. Weinstein and Adam, for that fantastic presentation. We'll now begin today's question and answer session. Please submit any questions you have by typing them into the Q&A box on your screen. We'll try and get through as many questions as we have time for. And one audience member asks, how have you refined your technique for all T-lifts and during use of this expandable cage?
I'm sorry, can you repeat that one more time?
Yeah, for sure. How have you refined your technique for all T-lifts and during use of this expandable cage?
Yeah. Well, I mean, I think that's a good question. 21 years ago, I think the whole concept of sagittal balance is becoming much more popular. And at the same time, when T-lifts were starting to be looked at as a somewhat of a potential issue in terms of not getting as much lordosis through the segment as you can. So I think over the years, we tend to do a lot more bilateral fasciectomies when we're doing our decompression. It does not really take much more than an additional few minutes sometimes. So I think that's been important, particularly with this cage. I tend to use a little bit more of a minimally invasive approach. Oftentimes, we can do a little bit less because we're getting a lot more anterior height. I think mobilizing the nerve roots is not quite as important because we're using a much smaller cage size. It's not uncommon to use an 8 or a 9 millimeter cage with an expandable device, as opposed to perhaps even a 10 or 11. And rarely will we go as high as, we don't use 13 expandables, but I would say our most common choice back in the day was more of a 10 or 11. I think 11 cages were very common. Now we're using 8 or 9 cages. So mobilizing the nerve roots, I think we really don't really do much of that anymore. So I think that's some of the ways we've changed a little bit of our approach to the T-lift.
Great. Thank you so much for clarifying that. Another audience member has a question about the specific approach to spine surgery. So why do you choose to treat this patient population from a posterior approach as opposed to an anterior approach at L4-S1?
Yeah, that's another good question and probably a highly debatable topic. I know even within our own spine community here in Tampa, but obviously there are inherent difficulties to treating L5-S1 from a lateral approach. Even L4-5 somewhat more risky for damage to the lumbar plexus. I've always been a fan of direct decompression. And in patients with severe stenosis, some of the degenerative stenosis and lateral recess stenosis in particular, doesn't improve that greatly with an indirect approach. A lot of indirect approaches require surgery from more than just anterior, more than just posterior. So particularly in the anterior approach, sometimes you have to go posterior as well. So I tend to like to take care of this all in one setting and one surgery, and hopefully that surgery will last a good 10 years. So I've always been a little bit more biased posteriorly, particularly with severe central stenosis. When it's just in the foramen, I do think that those particular procedures lend a little bit more better to doing indirect decompressions.
Awesome. Thank you again for pointing that out. Another audience member, question about the study. Did the study use any expandable interbody cages that expand in both height and width?
No, this study was purely looking at this FlexFit device. We didn't use any other device in the interbody space. Yeah.
Okay, thank you. This device appears to only increase in anterior height and lordosis. Other devices change in posterior and anterior height in a parallel manner with the lordosis built into the end plate. Can you explain the benefits of the device and method you use here compared to other expandables?
Yeah, I'm not sure I fully understand that question. It's somewhat similar to the last question. This device is large. It's a 40 millimeter length TLIF device, which again, there are not many of those, or not many of those are being used. So it allows us to get all the way across to the other side. It allows us to have the device placed along the ring apophysis, where really is the most important place to have it. I haven't really personally found much of a need to fill the entire space, especially if it's a device that takes up room for bone grafting. So there are some PEEK devices that can expand within both anterior, posterior, and lateral, but then they take up room for bone graft. So, and if you have too much of the device posteriorly, then it's somewhat hard to compress. So it might just be a bias, but again, we're able to get all the way across to the other side with this device. We have it on the ring apophysis. We're elevating height, and it's creating lordosis, and it allows us to then use the screws in the back to gain additional lordosis, and has been quite satisfactory. It might be an interesting study to look at this versus some of these other devices, but they seem a little bit more complicated, and certainly the revision strategy for those would be quite difficult.
That makes sense. Thank you. And following on from that, there's another question here from an audience member on changes in overall lumbar lordosis. The data showed the significant change in segmental lordosis, whether 1 or 2 level, but insignificant changes in global or overall lumbar lordosis. Can you explain why there were no significant changes in overall lumbar lordosis?
Yeah, I briefly alluded to that, but I do think it's important to highlight this because this is, I think, a very interesting finding, but one that's been also shown in some of the published literature, and we've seen at some of the unpublished meeting presentations. I think there's 2 reasons. Number one, I think for patients that are relatively young, so in our original study, 54 was the mean age of study, 62. The younger the patients, less likely, and the more that they have single level disease, the less likely they have overall lumbar lordosis that's outside of where they would want it for their sagittal balance, so within the PILL window. So I think those patients aren't really going to wind up in a place where they can't make postural adjustments at the other levels to give them overall the balance that they need to maintain. The second thing is, I think we're only doing 1 level, fusing 1 level or 2 levels. And again, when only 1 or 2 levels are fused, it allows patients to then find where they want their balance to be. And we know that in older patients, their balance tends to be forward. So if you take somebody who starts out with less lumbar lordosis than you would think they would need, but they're older, and you correct them segmentally, they may decide that that's not the balance where they want to be, and they wind up going a little bit forward again. So I think ultimately they find the lumbar lordosis that they need. So, when you're doing long fusions, you want to find the right balance for them. I think when you're doing short fusions, patients want to find their own balance. So especially in young patients, if they're fused with a relatively hypolordotic segment, and their balance is not there, they're going to hyperlordose at the adjacent segments and find adjacent segment disease. So that would be my best explanation for that finding that I think has been seen in other studies as well.
Absolutely, and thanks so much for expanding on that point there. We received a ton of great questions. We'll try and get through as many as we have time for in the next 10 minutes. The next one is, how do diagnostics, for example, X-ray, MRI, and discography, influence treatment decisions?
Well, again, I think MRI is very helpful. If patients have severe central stenosis, again, these are the ones that we're mainly doing with TLIF. If it's much more just foraminal, we would tend to, if we couldn't do them through a non-fusion type surgery, we would do them more potentially with an indirect decompression. Extreme foraminal stenosis, I still like to take off the facet, and so that would be a posterior. In terms of discography, we don't really use much of that anymore. I can't remember the last patient over the past even 10 years that I've sent for a discogram. We're not really doing a lot of dark disc back pain surgery. When we do, we'll tend to do them anterior posterior. But so we don't really use discography in our practice setting very much. So I don't really think that has much of a role for influencing how we choose our patients for these type of procedures.
That's really interesting. Thank you. Another audience member asks, how have your patient outcomes changed since using an expandable cage?
Well, that's a good question. I always thought we had good outcomes before. We have good outcomes now. I think the one thing that I have not seen in a very long time is the severe postoperative radiculitis that oftentimes you get when doing a T-lift and you're by the dorsal root ganglion. You have a collapsed space, especially in revisions when we're going through the foramen. It's hard to mobilize the nerve roots, and we would see on occasion this postoperative radiculitis. Patients would be complaining of pain. Usually they'd go to the patient's room a few days after surgery, and they'd be rubbing along their side by their buttock and their thigh, and it would go away with some steroids in a couple of weeks. But I really haven't seen that in a long time. And again, I think that's because we're able to put small cages into a small area and then expand them in situ in the interdiscal space. I think that's one of the main things we've seen. And then, having followed these patients out much, I think our longest follow-up is 4 or 5 years, but we don't have a lot of them. I think it would be interesting to see if they have less adjacent segment surgery as a result of the better segmental lordosis that we're able to achieve when we're not using a static cage and we're using an expandable cage.
Great, that is really helpful to understand. Another audience member asks, you did not mention SVA or PILL mismatch and did not achieve any improvement in overall lordosis post-op. So is it necessary to perform bilateral fasciectomies if you did not improve the overall sagittal parameters?
Yeah, that's a good question. Well, I guess when we started, we weren't expecting not to have any improvement. But again, if we look at our data, there's not the sagittal parameters aren't that off. In fact, many of the patients had normal sagittal parameters, but with a segmental kyphosis. So again, these are patients with single-level disease, so I'm not sure we'd always expect the sagittal parameters to be that off, and if they were off, they're off a little. But the bilateral fasciectomies are allowing us to get segmental lordosis right, because, again, as the early papers that in this presentation showed, and many papers have now showed, that degenerative single-level cases that in which we don't pay attention to the segmental lordosis wind up increasing the stress at the adjacent level, oftentimes resulting in hyperlordosis to keep the same sagittal balance, and that will lead to adjacent segment breakdown, stenosis, and further disease and potentially further surgery. So I do think that again, as a degenerative surgeon or when doing degenerative cases, you have to think about the segmental alignment in addition to the overall parameters, because oftentimes, and especially in the younger patients, the overall parameters for a segmental single-level disease aren't off. But if you throw them off, or if you potentially ruin a single segment, you can set the patient up for a lifetime of corrective spine surgery.
Thank you. And Dr. Weinstein, another audience member asks, what is your trialing process to determine appropriate height and lordosis?
What is the what? Trialing?
What is your trialing process to determine appropriate height and lordosis?
I think generally most people try to match the adjacent levels that are normal for height. There's no real there's not like a specific height that we're looking for generally. I don't like to increase the height certainly more than the adjacent level if the adjacent level is relatively normal. And I think in terms of lordosis, well, we've got relatively good parameters for that. At somewhere between L4 through S1 should be about somewhere around 36 degrees in general, and should be about 2/3 of most patients' pelvic incidence. So that's generally what we're looking for. I think when doing single level disease, the most important thing is improvement in disc height and foraminal volume, and I think it's also important to at least maintain the lordosis that's there, if not improve upon that as well.
That's great, thank you. And it looks like we've got another procedural question from another audience member here. Do you also place bone against the ALL prior to insertion?
Yeah, so when we do the TLIF, after we do the meticulous discectomy, and then we carefully prepare the end plates. First, we use an acetone and then a rasp. The next step is with a funnel. We then place typically 3 to 4 cc's of bone. That usually comes from the laminectomy, whether it's ground in a bone mill or whether it's the shavings collected in a bone trap. We usually mix it with a little allograft bone dust from the cadaver, and then that's placed in the funnel, and then we place the funnel in the disc base, and we apply the 3 to 4 cc's anteriorly before placing the cage, even before trialing if we decide we need to trial. After the cage is placed, which is packed with bone, we then place additional bone through a funnel dorsal to the cage.
Great, thank you. And it looks like we have time for about one more question. One audience member asks, it appeared that the change in segmental lordosis was less than the lordosis capability the device can achieve. Can you please explain the difference between the maximum expansion capability of the device and the lordosis achieved postoperatively?
That's an excellent question. I think part of that could be due to just measurement issues in terms of the position of the patient, whether the x-rays are perfectly orthogonal or not. And I know that seems like a cheap answer, but I do think there are certainly components of that. We sometimes have to send patients back as our x-ray techs shoot a patient who might be slightly scoliotic and they're not getting orthogonal, and so some of the times the plane of the x-ray is off. I think another part of that is when the cage expands in patients with soft bone, occasionally there'll be some impaction. So while the cage is expanding 15 degrees, we're only seeing 10 degrees, or expanding 10 degrees, we're only seeing 6 degrees, as there may be a little bit of impaction there. And then sometimes I do think when we compress posteriorly, sometimes we're not getting quite the placement of the end plates along the cage due to some tightness of the anterior longitudinal ligament. So I think all those things come into a factor. However, I know that if the cage didn't expand 15 degrees, we might not get 10 degrees of lordosis post-op, and if it didn't expand 10 degrees, we might not get 5 degrees of lordosis. So I think the expansion is important, whether or not each time it looks exactly like it's supposed to. Again, I think those are some of the reasons why. That's a good question.
Great. Thank you so much, Dr. Weinstein. And we had one late question come in, so I'm going to fire this one at you as well before we wrap up, if you don't mind. Is there a way to expand the cage a few months later?
I would presume that if you wanted to reoperate on the patient, you could, because if you had to take the cage out, and you could dock the expansion device in the cage, you could back it out. So I guess you could expand it later. I'm not sure. I would hope that a few months later you would have a fusion, and then there would be no need for that. I guess in a non-union situation, that's something that could be done. I'd have to have a much more of a discussion offline to understand why we want to do that, but I guess it would be possible.
Okay, well, thank you so much for sharing your insight there again and getting through all those questions. That is all the time we have for today. I want to thank again Dr. Weinstein and Adam for their excellent presentation, and CoreLink for sponsoring today's webinar. Please enjoy the rest of your day, and we look forward to having you join us for future webinars. Thank you.
Take care, everybody. Thanks.